Good morning. The topic for today's talk is, are we doing enough for BPPV with only maneuvers? My disclosures here. The sensors of the linear acceleration in our inner ear are secule, which senses the motion in the vertical axis, that is, while moving up and down in the elevator, while the utricle senses the sway, that is side to side movements in the transverse axis, and the surge, that is the movement during the anterior posterior axis, is being sensed again by the utricle. The sensors of angular acceleration, that is the three rotational axes of the head, are yaw, pitch, and roll. The movements in the yaw axis are being sensed by the horizontal semicircular canal, while the movements of head in the pitch and roll axes are sensed by the vertical canals, that is anterior and posterior semicircular canals. So what is BPPV? As per the American Academy of Otolaryngology, Head, Neck and Surgery, AAOHNS, BPPV is a disorder of inner ear characterized by repeated episodes of positional vertigo. Pathophysiology: the mass load of inner ear linear accelerometer, the otoconia, which normally remains embedded in the gelatinous utricular matrix, mixes with that of angular accelerometer, that is endolymph or cupula. It results in asymmetrical excitation or inhibition of the membranous labyrinth during the physiological head movements, resulting in short paroxysms of rotatory vertigo. So the semicircular canals, they work in pair during the angular head acceleration. For example, when the right posterior semicircular canal depolarizes and increases its firing rate, the left anterior semicircular canal hyperpolarizes and decreases its firing rate to the same extent, and vice versa. So likewise, the when right horizontal semicircular canal depolarizes and it increases its firing rate, the left horizontal semicircular canal hyperpolarizes and decreases its firing rate to the same extent, and vice versa. So these are the yoked pair of the semicircular canals, that is the right anterior with the left posterior and left posterior with the right anterior. So a state of no vertigo is maintained by the symmetrical firing of the paired yolk muscles. Whenever there is a asymmetrical firing of the paired yolk muscles, the vertigo occurs. So why it occurs in BPPV? In BPPV, inappropriate stimulation of canal after cessation of head motion leads to transient sudden asymmetry due to free floating otoconia in the canal, or sometimes because of a graviceptive heavy cupula which occurs asymmetrically on the one side because of the cupulolithiasis. So the BPPV variants are mass load of the linear accelerometer can reach different locations to result in different BPPV variants. There are at least 5 variants of the posterior semicircular canal BPPV, that is the periampullary, short arm variant, non-ampullary variant, the periampullary with associated partial canal jam, that is the SCOCO 2019 variant. Horizontal semicircular canal, 4 variants are known: the anterior arm canalolithiasis of the horizontal canal, posterior arm canalolithiasis of the horizontal canal, and the cupulolithiasis, which may be on the utricular or the canal side of the horizontal cupula. The anterior canal BPPV, there is one variant only, that is the canalolithiasis in the periampular region of the anterior canal. However, it is the least common of all. So total 11 variants of the monocanalicular BPPV and 3 variants of the multicanal BPPV exist. So 85 to 90% is the posterior semicircular canal BPPV, 10% is horizontal semicircular canal BPPV, and the less than 1% is anterior semicircular canal BPPV. Their frequency is determined by their anatomical variations, that is the in the upright position, and also while the patient is supine, the posterior semicircular canal is at the lowermost level, and if a otoconal debris it gets disintegrated from the utricular macula, it usually falls in the posterior canal near the periampullary region. So the typical posterior semicircular canal BPPV, they present with short episodes of positionally triggered dizzy spells lasting usually less than a minute. The Pathophysiology is that the otoconal debris detaches from the utricular macula and reaches the periampullary location of the posterior semicircular canal. The treatment is to reposition it back to the utricular macula by maneuvers, usually the Apley or Simon's maneuver. Yes, Apple maneuver is a reverse somersault. If this would have been possible to use this human golf ball, I would have been very happy to reposition with by this method. However, this is just an animation and not the real thing. So this is a lady, 38-year-old, came with the history of positionally triggered disease spells for 2 days. The right dicksalpine test shows right torsional upbeating positional nystagmus of less than a minute. So this is a right-sided posterior semicircular canal BPPV, the typical variant. So what is the treatment? The patient is treated. So how does this nystagmus is produced? The pathophysiology. When the patient is taken to the right dicksalpine position, there is an ampulofugal cupular deflections. Ampulofugal cupular deflection is excitatory, and the excitatory projections of the right posterior semicircular canal are to the right superior oblique and left inferior rectus, generating a slow phase VOR, which is downbeating, and left torsional. The positional nystagmus, which is a reflexive saccade, is therefore upbeating and right torsional during the right dicksalpine test in a patient with right-sided periampullary located posterior semicircular canalolithiasis. So this is the right apply maneuver which I am doing here. Position 1 being maintained for 1 minute. After 1 minute, the patient is taken to the head is inclined 90 degrees to the opposite non-involved side, and this position is again maintained for 1 minute. After which the nose down position with lateral recumbent to the non-involved side is done, completing the one apply maneuver. A verifying supine dicksalpine test on right side was done 24 hours later, and there is no elicitation of any type of nystagmus and accompanying vertigo. Patient is free of vertigo. The horizontal semicircular canal BPPV is slightly dicey in that we require supine roll test, which is also known as the lateral head roll test or head yaw test, or also called the Pagnini Macure maneuver. Here, the lateral head roll to right as well as left either elicits a geotropic positional nystagmus, which is horizontal nystagmus, the quick component of which is beating towards the earth on lateral head roll to left as well as right. In the apogeotropic variant, the quick component of the nystagmus beats away from the lowermost ear on lateral head roll to left as well as right. See here, if it is geotropic, it will be geotropic on lateral head roll to either sides, and if it is apogeotropic, it will be apogeotropic on lateral head roll to either sides. That's why it is called direction reversing horizontal positional nystagmus during the lateral head roll. That is the characteristic of the horizontal semicircular canal BPPV. So how does the geotropic and apogeotropic implies? As a son of botanist, I have been hearing these terms, the positive geotropism and negative geotropism. Positive geotropism, that is the roots, they grow towards the gravity, and that's why the geotropic means the quick component of the nystagmus beats towards the earth. The shoots, they show the negative geotropism, that is the apogeotropic positional nystagmus beats away from the earth. So in the context of the lateral canal BPPV or the horizontal canal BPPV, the geotropic implies this sort of thing: quick component towards the earth and slow component away from the earth, and it will be present on either side. The side that elicits the stronger geotropic positional nystagmus is the diseased side, as you will recall that the lateral head roll to both right as well as left produces the geotropic nystagmus. So which is the site involved in the geotropic variant? It is the stronger geotropic of the two nystagmus during the lateral head roll is the disease site. The apogeotropic, the quick component beats away from the lowermost ear. Here it is seen. This is quicker, slower, quicker, slower, quicker. So the side that elicits the weaker apogeotropic positional nystagmus during the lateral head roll to right and left is the disease site in the apogeotropic variant of the posterior of the horizontal semicircular canal BPPV. So the geotropic posterior semicircular canal BPPV, this is a 19-year-old boy, came with the history of positionally triggered disease spells for 2 days. The supine roll test, supine neutral position. On lateral head roll to right, it shows a geotropic nystagmus quick component beating towards the lowermost right ear. On lateral head roll to left, now being shown, a geotropic nystagmus with quick component beating towards the lowermost left ear is seen, and here on lateral head roll to the left, it is stronger, so it localizes to the left ear, that is left-sided geotropic horizontal semicircular canal BPPV due to left long non-ampullary arm horizontal semicircular canalolithiasis. So what did I do? From the short sitting, the patient is taken quickly to the non-involved right side for 2 minutes. After 2 minutes, the head is inclined around 45 to 90 degrees and kept in that position for 2 minutes. After which, the patient is uprighted, completing the one Guffoni maneuver. In our center, we do two Guffoni maneuvers in one session, and we re-examine the patient after 1 hour to look for the elimination of nystagmus and concomitant vertigo. That is called the verifying supine roll test. 1 hour after the Guffoni maneuver. So here we tested the lateral head roll to left first, which was not showing any nystagmus. On lateral head roll to right, no nystagmus, absolutely static eyes, and the patient is free of vertigo. It is 2019, and the patient is free of vertigo even after 6 years. So what happened? The otoconal debris, which was in the long posterior arm of the horizontal semicircular canal, shown in the figure A here. As the patient is taken briskly to the right lateral recumbent, the horizontal canal becomes vertical, and it reaches the otoconal debris reaches near the vestibular opening, and in the nose down position, when the head is inclined downwards, the debris moves into the utricular macula, and on uprighting, the canal clears. So also the clearing of the symptoms as well as the diagnostic positional nystagmus. Apogeotropic horizontal semicircular canal BPPV. This is a lady around 42-year-old, came with the history of positionally triggered disease spells for past 2 weeks. This is the supine neutral position. On lateral head roll to the right, it shows a apogeotropic horizontal positional nystagmus. The quick component of the nystagmus is beating away from the lowermost right ear, and this nystagmus is persistent. This lasted for almost a minute, almost 3 minutes, in fact. So this is now 1 minute. I am scrolling it to 2 minutes. It is still present. At 3 minutes, it is still present. So after 3 minutes, we decide to do a lateral head roll to the left and look whether the same pattern of the direction reversing apogeotropic horizontal nystagmus occurs on left lateral head roll. Here we do left lateral head roll, and we see a direction reversing apogeotropic horizontal positional nystagmus, which is weaker as compared to that on the right lateral head roll. It also lasted for around a minute. Scrolling it forward. So, as we had previously said, that the side that evokes a weaker apogeotropic horizontal positional nystagmus is the disease side, and in this case it is the left side. So what did we do? Head shaking. The patient's head was antiflex 30 degrees and it was shaken side to side for around 30 seconds at the rate of 3 cycles per second. It is called high frequency head shaking, which is a diagnostic test as well as it is a test therapeutic maneuver for the apogeotropic variant of the horizontal semicircular canal BPPV. So again, a verifying supine roll test is mandatory 1 hour and preferably at 24 hours after the head shaking maneuver, and we did that. Supine neutral position, no nystagmus. On right lateral head roll, there is no nystagmus and accompanying vertigo. On left lateral head roll, there is no positional nystagmus or vertigo, and the patient is cured by just a head shaking maneuver in the anti-flexed head position for 30 seconds, and she had a suffering for past 15 days. That is the beauty of treatment, successful treatment of benign paroxysmal positional vertigo. So, in this case, the otoconal debris was possibly on the utricular side of the horizontal cupola. That's why when we generated the inertial forces by the brisk head shaking, the debris got detached and it dispersed into the utricular macula, leading to immediate relief. The follow-up of BPPV patients who undergo therapeutic maneuver is very crucial. Positional retests are mandatory at short-term follow-up to look for success of this therapeutic repositioning maneuver. Canal switch roughly occurs in 6% of the cases. What happens that we have treated, say for example, posterior semicircular canal BPPV, it is repositioned back by the app play or the Simon maneuver. The otoconal debris gets adherent to the utricular macula, but it re-detaches and enters the horizontal semicircular canal. Then it is called a canal switch, and most common is from the posterior to the horizontal semicircular canal. In our center, we conduct positional retests at 1 hour and after 24 hours after the therapeutic maneuver in each and every case. So, inadequate or failed responses to the maneuvers, there are three I's: incorrectly chosen maneuver, inappropriately executed maneuver, the angle is very important, especially in the apply maneuver, inadequate number of maneuvers, number of therapeutic repositioning maneuvers, posterior semicircular canal BPPV, a total of 5 apply maneuvers or cement maneuver effective in almost 100% of the patients as per the American Academy of Otolaryngology head neck and surgery guidelines of 2017. Horizontal semicircular canal BPPV, a total of 2 Guffoni or Appiani maneuver effective as per the Kim et al. 2012 and Mandala et al. 2013. Anterior semicircular canal BPPV, it is so infrequent that there are no clearly specified in most studies. In my personal choice, it is 5. So the residual dizziness after the successful repositioning, multi-canal BPPV, the short-term posterior semicircular canal BPPV is co-occurring with 40% of the typical posterior canal BPPV as per a recent study from the South China. Cupulolisthesis require other methods like the head shaking or the mastoid oscillations or the things like Zuma maneuver. Canal switch, superimposed functional dizziness, which is called persistent perceptual postural dizziness, co-occurring central positional vertigo because of the vestibular migraine. So, how to deal with the residual dizziness after BPPV? This is one of the articles from May 2024, Frontiers in Neurology. They say that in some studies, beta histine as an additional therapy to the canalith repositioning maneuver or vestibular rehabilitation therapy has been reported to reduce the positional vertigo. However, they say that further research is needed to better define the patients in whom beta histine offer clinical benefits and to target underlying cause of their BPPV as well as. About vitamin D, there are no yet consistent evidence that correction of vitamin D insufficiency cures or prevents the recurrence of BPPV. There is another article from the Egyptian Journal of Otolaryngology, and this was published in again 2024. Beta histine in the treatment of peripheral vertigo, an evidence-based review. It says that studies analyzed compelling evidence on the benefit of beta-histine when associated with replacement maneuvers to control symptomatic vertigo and reduce the episode reoccurrence, which underlines the important role of beta-histine in the control of BPPV. So, dual therapy was considered better as compared to the maneuvers alone. Thank you very much. I finished.